All right, welcome back to another session of our community health series. So I'm Dr. Tanzila Basrin. I'm a family and emergency doctor in the GTA area. And I'm really happy today to have our amazing cardiologist, Dr. Hassan Mir. So Dr. Hassan Mir is a cardiologist at the Ottawa Heart Institute and an assistant professor of medicine at the University of Ottawa. He received his honors in life sciences at McMaster, then went on to complete his undergrad medical education at Western University. And then from there went to finish internal medicine residency as well as a further residency in cardiology at McMaster University. He then didn't have enough and went on to do additional fellowship training in advanced echocardiography and cardiovascular prevention at the University Health Network in the University of Toronto. He has a strong interest in clinical research and recently completed a program on clinical effectiveness at Harvard University. He's currently doing a master's of health informatics at U of T, as well as a master of public health at Harvard Chan School of Public Health. So, with all of this, he's also had numerous outstanding clinical research and leadership skills at the local, national, and international level. And I won't even get started on his awards. So, without further ado, welcome Dr. Hassan Mir, our amazing cardiologist who will be talking to us all about heart health today. How are you?
Fine, thank you. Thank you so much for inviting me to speak, and it's my pleasure to hopefully speak on the topic of cardiology to our audience. So thanks so much again.
All right, so I guess to start, what is heart health? When we think of cardiology, we're focusing strictly on this organ, but what does it encompass? Is there more to that?
Yeah, that's a great question. So when we think about heart or cardiovascular health, we often will think about the heart. And obviously, I'm extremely biased. The heart is the most important organ in the body. But beyond that, we think about peripheral arterial disease as well as cerebrovascular disease. So just to put that in simpler terms, so we've got the heart, we've got the brain and plumbing issues relating to that, as well as any arterial blockages that happen in any of the arteries or veins in the patient's body, whether arms or legs. But when we focus specifically on the heart, then there are a few areas where issues can happen as it relates to the heart. So it can be issues with blockages of arteries. It could be issues with the electrical activity of the heart. It could be an issue with the pumping function of the heart, or it could be an issue with the valves of the heart. So we try to think about the heart like pipes and pumps. And so, there's four major issues that can happen with respect to the heart.
All right. So, what do you think are the most common ones that people encounter, like that you encounter as a cardiologist and people experience?
Yeah, for sure. So probably the most common reason for referral to a cardiologist is chest discomfort, whether in the outpatient clinic setting or in the setting of somebody coming into the hospital with sudden chest pain. And so heart attacks or coronary artery disease, where the pipes that provide blood to the heart start getting plaques or cholesterol buildup inside of them, and it reduces the amount of blood flow to the heart itself. And so that's probably the most common reason. So heart attacks and heart disease as it relates to blockages of the arteries. And as I kind of implied, when that happens slowly, and you can be seen in the outpatient setting in the clinics, that's typically something that builds over time. Or it can happen suddenly and you need to go to the hospital in an emergency because that's you having a heart attack. And so that's a sudden blockage of the artery and needs, again, immediate management. So those are probably the two main reasons. And then there's others as well, obviously, as it relates to congestive heart failure, if the pumping function of the heart is not normal, atrial fibrillation, when the heart starts acting very fast, or the opposite, where the heart is very, very slow. That's when people need pacemakers. So those are probably the most common reasons why we get referrals for patients.
All right. So, I have lots of family members, and before I even got into medicine, the big question everyone, whenever you think of heart, you think of heart attack. And I know, as you've mentioned, there's so many different heart conditions that we think of as physicians. But let's talk about the heart attack. How does that truly present, and what makes us worried to go to the hospital versus talking to maybe the family doctor or whatnot to get things started, and then ultimately seeing you?
Yeah, so it relates to the fact if somebody's having a heart attack, what is happening is that within the artery, for some reason, there's been a small tear, which has caused formation of a clot. Just like if you cut your arm and you see that a clot forms on your arm, and that is meant to stop blood from leaking. In the same way, that can happen inside of our arteries as well. But unlike the arm, where the clot can build as big as it wants, in the arteries, they're very narrow. So if a clot builds inside there, then it can actually stop the blood flow from the front to the actual muscle of the heart. And that's really what a heart attack is that for some reason there's been a small tear. Your body appropriately goes and tries to fix that tear. It builds a clot there. That clot, unfortunately, stops the blood flow to the heart. And then because of that, you start feeling symptoms, which we'll get into shortly. And those symptoms tell you that you need to go get medical attention immediately because your artery is blocked and needs to be opened up. Now, what are those symptoms? So we typically think about patients complaining of severe retrosternal chest pain. So in the front of their chest, they feel severe pressure or tightness, or somebody sitting on their chest. Those are some descriptions that we often hear. And it may go and radiate into the jaw, into the neck, down either arm, or into the back. And so that is where it would typically radiate. And any degree of exercise or exertion may make you actually have worse pain. And so that's typical of cardiac pain, where the more you exert your heart, the harder your heart has to pump, and the faster it pumps, the more work it does. And then there's a cycle where it actually feels like it's not getting enough blood. And that's the symptoms that you start getting of chest discomfort, nausea, vomiting, sweatiness. All of these things are common symptoms of somebody who may be having a heart attack.
Oh, sorry there. Okay, so actually that brings me to an important part. So, we're always learning about the differences in presentation. So different groups sometimes don't present with that typical pressured chest pain. So do men and women present the same way? And, are there other people who might present differently, other groups of people?
Yeah, that's a great question. So, the common teaching is that the majority of patients that come in with a heart attack specifically are likely going to present similarly with that severe chest pain radiating down either the arms or the jaw or what have you. But women are often more likely to present atypically, meaning that they don't have those typical symptoms of severe retrosternal, like chest discomfort that radiates down the arms. And so they may have, feeling of unwell. They may have a feeling of shortness of breath. They may have palpitations. So they may present atypically more so than men. But the majority of women will still typically present with those common symptoms. The other individuals we often think about obviously include those that might be diabetic, and they may not have the typical chest discomfort symptoms that another individual may have, because diabetes affects your neurological system, so how your body is feeling, and it may not feel in the same way that somebody who's not diabetic would feel. And then beyond that, we often will have patients that are elderly, and so they may feel things very differently. They may just feel something is off. And even within our population that may have dementia or Alzheimer's, they also may not be able to describe what is actually happening to them, and they just may be more agitated. And so there are different groups that may present differently, but on the whole, we always think about the typical presentation of if you have chest pain, if you have radiation, if you're feeling sweaty and nauseous, all of those things should make you think about the heart. One thing I'll just mention is often when I'm working in the hospital, we'll have people who are in their 40s and above, and they'll say, yeah, I had chest pain, but I didn't think I had a heart attack, or I thought heart problem. I just left it for a day or two. And I think that's very dangerous. I think as soon as you're over the age of 40, and if you happen to have any risk factors like being overweight or being from South Asian ancestry or high blood pressure, diabetes, cholesterol, we'll talk about some of these a little bit later. But if you have these risk factors, and smoking, of course, if you have these risk factors, you really should, if you feel chest pain, that needs to be checked out. And if you're feeling that for more than 15 to 20 minutes, you should call 911. This is not the time to assume that it's something else. And often, unfortunately, some of our worst cases we see of young patients that think, no, I don't think I have a heart attack, but it is actually a heart attack. So early recognition and assessment and management is extremely important.
All right. Yeah, no, and you touched on those risk factors. So I know in the emerge department, I'm profiling a little bit too. But at the end of the day, if you're coming in with chest pain, we do an ECG, right? So we don't want to miss anything there. So I guess that brings us to, how about in the office? Let's say, I often have patients who say, I had chest pain last week. I was shoveling the snow and I had pain and then I took a little break and I was fine. So I just didn't think much of it. What do I do now? Right. So, I know what I would do. But then, it requires tests potentially if they meet the picture. And those tests involve sending them to you. So what do you do on your end?
Yeah, I think that's a great question. So, I like to think about individuals in terms of their pre-test or before you do any sort of test. What is the likelihood that I think they have some sort of an issue? And if and depending on where that ranks, I'll determine what the next steps are. So let's say I have somebody who is 60 years old, is a smoker, has high blood pressure, is having severe chest pain every time they exert themselves. When they stop, they get better. And then, it's something that's consistently happening, but happening with less and less activity over time. Those are concerning findings for me, especially in somebody who's 60 with very typical cardiac symptoms. So in those individuals, it's pretty straightforward. We're going to go forth and order something called an angiogram. And that within that test, they go through your wrist and use wires and catheters to get to the heart and find where the blockage is. And the reason we jump straight to an invasive test, which is more internal, and the reason we do that is because the likelihood that there's some sort of a problem with the heart is high. So that makes life easy for everybody involved because we say you're at high risk, we're concerned about your symptoms, you need to go and get this invasive test done. That's the gold standard to see, is there a blockage in any of the arteries? And the good thing about that test, which is the angiogram, is that if there is a problem, they can go ahead and fix it right away. Okay. Now that's a simpler path. Now the other path, I'll keep it simple as well, is let's say you're a 19-year-old male and you're somebody who's completely healthy, and you tell me I get chest discomfort when I go for some fast food and eating heavy food, and it only happens when I eat certain foods. It's in that person, I'm suspecting that they don't have any issues with their heart based on the history itself. And typically we'll do something non-invasive like an electrocardiogram just to make sure that there isn't anything going on there. And we may not need to do any sort of testing because they're young and considered to be extremely low risk. The middle ground is typically where the majority of our patients sit, right? And that's where things get a little bit more interesting and become a little bit more complex. So if you happen to be somebody who's in the middle age and describes symptoms that are not entirely typical that we talk about, like, oh, I get chest pain when I exert myself, when I stop exerting myself, it gets better, and it's right in my central chest. Then we have to think about non-invasive tests because we don't really want to put you under an invasive test that may come with certain risks, but we may want to do some non-invasive testing and so typically what you can expect is first and foremost, we'll do an ultrasound of your heart that's completely external. They'll take a look of the pumping function and the valve function of the heart. And that tells us about the structure and function of the heart. The ultrasound of the heart is probably the most commonly used test that we get done. And so you'll often have patients that are referred to a cardiologist that have that test done. And then from there, we'll typically do an ECG stress test. So pretty much what that means is we get you on a treadmill, we get you to do exercise while we have electrodes on you, and we measure the electrical activity of your heart. And then based on that, we'll determine if this is an abnormal or a normal test. If that's a normal test, we can stop right there. We don't need to do anything further. If that turns into an abnormal test, then we may need to do additional testing, which may eventually, if they continue to be abnormal, take us down the path of the angiogram. So that's just to give you an overarching view as to how we think about patients that are referred to us. And if you're low risk, you may not get any testing. If you're high risk, we may go straight to the angiogram. If you're in the middle, we may consider doing these non-invasive tests.
Right. And sometimes you'll end up getting these tests before we get to see the cardiologist. But I know Hassan is busy reading those studies and doing that final report. So it's a lot of analyzing. So you're the right person to ask the question. So
absolutely.
The other part I want to ask about is, let's say, I'll start. So we have a patient who's in the emergency department, and so they are here. I'm looking at the ECG. I see that they have a heart attack. So my next thing is obviously I'm calling you. or sending them off to the Ottawa Heart Institute or wherever the nearest cath lab is. And when we say cath lab, we mean the nearest place where the cardiologists are going in with that angiogram, where they're going in and opening up that blockage, right? So you have someone there. What does that process look like? What does that procedure look like? And what are some things to think of after you've had that procedure done?
Yeah, so when we think about heart attack, so we're now focusing specifically not in the clinic setting, but in the emergency care setting. You're coming in with severe chest discomfort, you see an emerge doc such as yourself, and you diagnose them with a heart attack. When we think about heart attacks, there is some that are major heart attacks, which means that the artery is 100% blocked, and that's something called a STEMI, and that needs to be fixed immediately. So within the 2 hours from the time that you walked into the door until that artery is opened should be less than 2 hours. So that's a ST elevation
so time
marker.
sensitive. That's the part I
Yes,
really want the
exactly.
viewers to get. It's so time sensitive. Don't ignore it.
Exactly. Exactly. And that's why we always say, if you have chest pain, please get medical attention immediately, because it's extremely important, because everything is time sensitive. You can imagine a pump that is meant to be supplied, or if you say you have a pipe that's providing water to flower beds, and that pipe is blocked for a week, those flowers are probably going to die. And similarly, unless you unclog that, it's not going to get better. And so in the same way, the arteries provide blood flow to that muscle, which is a flower bed. And if that isn't opened up, if that pipe isn't fixed, then you're going to have major issues with the pumping function of the heart. So yeah, if you have an emergency like that, if you have a major heart attack, that needs to be, so what happens is you'll be seen by the emergency medicine team. You'll get some medications that are given to you, including two chewable baby aspirins. And then they'll give you some other blood thinners to try and keep that artery open until the transfer to the other site. You'll be likely transferred from the hospital that you're at to the hospital that has the angiogram capabilities, which in Ontario, there's only about 16 angiogram centers. The rest of the hospitals have to transfer patients to those hospitals. And so eventually when you get there, you'll be assessed by the interventional cardiology team, and they'll ask you some questions about what's going on. Then, as I mentioned, they'll prep your leg as well as your wrist. They'll typically go through the wrist, they'll clean that area, and then using wires and catheters, they'll go into the heart and use contrast dye to take pictures of the heart using x-rays, and they'll see where the blockage is. Where they find the blockage, they stick the wire through it because it's nice and soft, and then they use a balloon to crush that plaque against the wall, and they'll put a stent in place to keep that area open. From there, once that's completed, patients will typically be sent to the CCU at that hospital, so the coronary care unit, which is the cardiac ICU type situation. And over there, you'll be there for about 1 to 2 days, recovering, after which point you'll go home.
Sorry, I think this is my camera there. So actually, a really common question I have from patients is, what can I and can't do after open heart surgery or stenting or whatnot, whatever it may be. I think, those who've had an active heart attack are quite scared of re-triggering it. What are the risks of that, and what are some things we should and shouldn't do?
Yeah, that's a great question. So I guess before we get to that level, one should be aware of the fact that once you've had a heart attack, you're going to be going home with several medications. And these medications are life-saving medications. These medications have been shown in large clinical trials with lots and lots of long-term follow-up to be helpful for patients. So the first is baby aspirin. If you've had a heart attack, you're going to stay on a baby aspirin for your entire life until a physician such as myself as a cardiologist tells you otherwise. Unless that happens, you should stay on a baby aspirin for your entire life. The second is another blood thinner that you go on. It's like aspirin, and that's meant to keep that stent open for the first year until that stent is taken up by your own tissue. And so, then it gets covered up by your own internal cells, and then you can come off that second blood thinner. But for the first year, you'll be on 2 blood thinners. Then the third medication that you'll go home on is called a statin medication. So that's a cholesterol medication. And that works not only to reduce your cholesterol levels, but it also has anti-inflammatory capabilities, which also reduces your risk of a future heart attack, stroke, or death quite substantially, about 25 to 30%, which is very large. And then there's two other medications that we think about that are beta blockers, which reduce the workload of the heart, as well as ACE inhibitors, which reduce the blood pressure and also avoid scarring within the heart. So these are the typical 5 medications every single patient who's had a heart attack will go on. The other medication is a nitro spray that if you have recurrence of symptoms, then you would consider using the nitro spray to open up the arteries before you call 911 if something happens. So assuming you are doing wonderfully, you're taking those medications, you're going to be sent home, then as Dr. Basrin said, often questions will arise about what I can and cannot do. So typically what we advise patients is after a heart attack, you want to take it easy for the next week or so. And by that, it just means gentle walks, starting off by 5-minute walks or 2 5-minute walks, then increasing that to 1 10-minute walk, and then adding incrementally thereafter. In terms of weights, we advise patients not to lift more than 10 pounds of weight until they get connected to a rehab program, if that is available in your area, which we do have available at the Ottawa Heart Institute. And once you are, and also at the Toronto Rehab Institute, where I've done my fellowship, and that is also available at McMaster and also in London and many major areas will have these rehab programs. So you'll get referred to the rehab program where they'll come up with an exercise prescription for you based on how much exercise you can and can't do. And that's individualized to yourself. But typically we say you should be walking. And by the end of the first month, hopefully, depending on the type of heart attack you've had, you may be able to do more walking. We don't really want you to be running and jogging until you've had an assessment by the cardiologist after your heart attack, which typically happens about 6 to 8 weeks after your hospitalization. Another important thing to consider is if you've had a major heart attack, you're not allowed to drive based on the ministry's recommendations for at least 1 month. If you've had a major heart attack, which is a STEMI, and that's your personal car, and you shouldn't be flying anywhere for 6 to 8 weeks. So if you have any plans booked, then that should pretty well be canceled. And the reason is that you won't have insurance. So if anything were to happen in the plane, or if anything happens in the other country that you're in, then no insurance company would have covered you, and you run into major issues. If a plane has to be rerouted, that's $50,000 to $100,000 that you'd have to be liable for. So, and also you obviously want to just look after your health locally where everybody knows you. So really within the first 6 to 8 weeks, you shouldn't be traveling too much. Now, if you happen to be a commercial truck driver, as an example, then it's not 1 month as it is for private driving. It's actually 3 months. And you can't be driving a commercial truck if you're a truck driver or whatever it may be, taxi driver, et cetera. That's 3 months. And the reason is that there may be other people that you may put at risk. And so that's important to know. And, typically people will go home, and I often hear from my patients, they're very depressed often. So we have to be very mindful for mental health and mood issues. I do try to reassure them that I have many patients that are under my care that are actually healthier after their heart attack than they were before. And I actually have a patient of mine, without going into details, that ended up actually being so fit that he was able to compete in marathons after his surgery. So, it's not to say it's all doom and gloom. It's to say this may be the right kick where you need the incentive to really exercise more and take care of your health and really prioritize yourself.
For sure. And actually that gets right into the next thing that I want to talk about is how do we prevent these things? How do we prevent heart disease? And actually, we don't talk about stroke, which is actually part of your department too, which is still a blood vessel from the heart to the brain, and all the pumps and plumbing in our body. How do we prevent it from getting clogged up and causing heart attack-like things in all our organs, from our brain to our legs, arms, all of these issues? What do you want us to do?
Yeah, so I think that's a great question. And it's not only after your heart attack, but hopefully these things are being
so we don't get there. We do not want to be in the hospital.
Done before your heart attack. So hopefully our viewers are doing this before they get the heart attack. Prevention is way better than trying to deal with these issues after the fact, right? So whenever we think about what can we do to avoid these issues. So the first and foremost thing, that if somebody happens to be a smoker, smoking is the #1 risk factor for heart disease and stroke, and so or peripheral arterial disease. So you ideally want to stop smoking. And there are lots and lots of programs, including the one that I'm involved with at the Ottawa Heart Institute called the Ottawa Model for Smoking Cessation. And that is something that's available to you remotely. And we're doing virtual visits, and we're doing counseling virtually, et cetera. And it's all free for anybody who's interested in quitting. So smoking cessation is probably the most important thing. Then we talk about risk factors. And so things like if you have high blood pressure, managing that, making sure that you're taking your medications. If you have high cholesterol, making sure that you're managing that. And we'll talk about that briefly in a second. But whether it's medications or non-pharmacological things like watching your diet and exercise. If you're diabetic, making sure your sugars are well controlled. If you happen to if you're somebody who's not exercising, making sure that you're exercising at least 150 minutes to 200 minutes a week. If you happen to be very, very, not conscious of your diet, then being conscious of your diet in terms of the carbohydrate intake, in terms of the fast food and processed food intake, and ideally following a Mediterranean diet. And again, we'll talk about that a little bit more in a bit. And then if you happen to have a lot of stress in your life, that is definitely a risk factor as well. And we advise people to meditate or pray or whatever activities they can do to try and, yoga can sometimes be helpful, whatever helps them de-stress. We tell them about that as well. So these are some of the things that you can do from the perspective of prevention. There are some things that you can't do anything about, which I think is still important to mention. So obviously the biggest risk factor that you can never change about yourself is your age. So the older you are, the more likely you are to get a heart attack. Your gender or your sex, that is. So if you happen to be a male, they tend to be at higher risk. And then depending on your genetics or your ethnicity, and we know South Asians are at higher risk of heart disease as well. So those are factors that you can't do anything about, unfortunately, but the ones that I listed before, there's a lot of things that you can do about managing those. And those modifiable risk factors are really, they explain about 90 to 95% of your risk. And so if you can adjust those and manage those, then really you'll be much better off. If you've happened to already had a heart attack, then obviously medication compliance, or even before, I guess in terms of management, medication compliance becomes extremely important. And if you don't take your blood thinners, if you don't take your cholesterol pills, and et cetera, then you're going to have recurrence of heart disease for sure.
Yeah, so it's interesting you said a few things. So in terms of the exercise, do you guys have specific guidelines that you recommend,
for sure.
like minimum?
Yeah, so from the perspective of the heart, for cardiac health, we typically advise at least 150 minutes. So that's typically about 30 minutes a day, 5 days a week, but ideally should be 7 days a week. And ideally you should try to do 60 minutes in an ideal world, but at least to do 30 minutes, 5 days a week. So 150 minutes of moderate intensity exercise. So that means you're walking at a pace that you can't very easily hold a conversation. This is not like a gentle walk. This is you're walking for the purposes of getting your heart rate up. So that's moderate intensity. Or if you're on a bike, you're biking, you're sweating a little bit, but not to the point where you cannot even say a word. That would be high intensity. So moderate would be that you're able to speak. Yeah, you're able to speak a few words without major issues, but you can't speak full sentences as though you're having a conversation sitting on a couch. Right. And so moderate intensity, 150 minutes is advisable. We do typically advise all 3 different types of exercise. So we talk about cardiovascular or cardiac aerobic exercise. So that's treadmills and ellipticals and bikes and things like that. We also talk about stretching. So, making sure that your different muscle groups are appropriately stretched and, making sure that you're flexible. And then we talk about weights. If this is pre or post heart attack, you can obviously do a lot more if before you've had a heart attack for weight training, and there's a lot of different programs that one could do. But we do typically advise all 3 because all 3 are beneficial.
Okay, perfect. And I guess the other risk factor is the smoking cessation part. And I just want to put my little pitch in. So for those in the community who don't know, there are medications to help for smoking cessation. So if you are somebody who's been trying to quit for many years and you're having a hard time, speak to a family doctor, go to a walk-in, speak to somebody about that, because we do have help for that, right? So it's not all on you, but it is on you to make that appointment and take that step if and when you're ready, because we know that that's a huge risk factor as well. Now,
Yeah, the
about
one thing
diet. Oh yeah,
I'll
go
just
ahead.
mention about the smoking cessation, because it is an area of research and clinical interest of
Okay.
mine. I am the co-medical director of the Ottawa Model for Smoking Cessation. So we do a lot of research activities and different things. The one thing I will say is that you can even talk to a pharmacist, and you can also get free medications. So not only if you have a drug plan, but even if you do not have a drug plan, there's a lot of access to free nicotine replacement, which is the usual primary means of smoking cessation. You can buy that over the counter, or you can buy that, or you can be given that from public health, and it'll be covered. So, for example, if you happen to be joining our Ottawa Model for Smoking Cessation, where patients can easily be referred, then you would get free supplies of nicotine replacement. So there are a lot of opportunities in that way. And beyond the nicotine replacement, there are other vehicles for cessation, whether they're medications. We know that being healthy, exercising, being in a happy mood, just through all of these things can also help you with smoking cessation. So I would absolutely say, for somebody who smokes, the biggest risk factor you have is the fact that you smoke. And every day that you continue to smoke adds to that risk. But when you quit, there's drastic improvements that you can make to your life. It's never too late. We've seen people who are 60, 70
100%.
who smoke for a long period of time and were able to quit. And you can improve your quality of life, and you can improve the longevity of your life, and you can improve the quality of life longevity as well. So it's like, really absolutely the best thing you can do. And if you were to combine the effect of all of the medications that I've just talked about in cardiology, you stopping smoking would be the equivalent of you taking those medications. It's that important. So I
Wow.
can't stress it. I cannot stress it enough that stop smoking, if at all possible. As Dr. Basrin said, talk to a healthcare professional, whether it's your family doc or a walk-in or a pharmacist, social worker, anybody, if you're interested, and reach out and get help, because that is the best thing you can do for yourself.
And it's not just the heart; it's every blood vessel, and it's your lungs too. And more to come on that on our lung health month. But yeah, it's everything. It's changing your life around.
And
So I
also
do.
cancer, like,
Oh
we
yeah,
talked about
oh
heart
cancer,
disease, but
COPD,
cancer,
asthma,
again.
COVID, infection risk, all of it. So if there's one thing to take away, that's one for sure. So this may be a little bit more controversial, but I have a lot of people asking about diet, and I know you mentioned a few. What about intermittent fasting or keto diet or the carnivore diet and all of these things that keeps changing every now and then? What are your thoughts, and what do you know maybe about these diets, and what do you recommend?
Yeah, that's a great question. So, I think the one thing to be mindful of is that in medicine, when we're practicing, we want to practice based on the best evidence, meaning that there's adequate trials that have been done in that particular area. So we're telling you what the right thing to do is based on what we think and know, based on evidence and trials that have shown to us has been effective for you. And the reality is that in the nutritional world, or the nutrition science world, there aren't a lot of high quality long-term follow-up trials that have been done. And so we often have people tell us about different fads, whatever they may be, in whichever direction that we want to talk about, and they'll push the diet as though it is the be-all end-all best diet that's ever existed, and it's going to cure cancer, heart disease, and inflammation throughout your body. Which is, the reality is that if something seems a bit too good to be true, then you probably want to start asking questions about what the degree of evidence is for that. So, speaking as a cardiologist who's obviously involved in cardiac rehab, the current evidence that I'll focus on relates to the Mediterranean diet. And so the Mediterranean diet typically is a diet that's high in fruits and vegetables. It's high in fiber. It's typically high in things like olive oil, nuts, fish, those types of things. And it's typically low in red meats, it's low in carbohydrates, and it's low in processed foods, refined foods. And I think those are probably good principles to apply. So, and when I say that it's been tested, it's been shown to reduce the risk of future heart attacks and the risk of future death. So this is probably the best studied diet. And it makes sense. It's been shown through other large trials that are observational, in many ways. Fruits and vegetables and vegetarian diets are likely better for you in terms of you avoiding future heart attacks and death and what have you. So typically we'll advise a high fruit and vegetable diet and fiber diet, which kind of goes along with the fruits and vegetables. We try to tell people to avoid junk food, processed foods, eating out at restaurants, eating high amounts of meats, especially those that are red meats. And, we talk about hot dogs and burgers and those types of meats that have been prepared in a certain way. Those are not ideal for you. So we typically will discourage the use of those. But ideally, you want to, there's a lot of other things you can eat with fruits, vegetables, and fiber, and those other things that I've mentioned.
How about intermittent fasting? I know there is some evidence, for those who have diabetes and there's weight loss things. I mean, they all are supposed to do weight loss, but what are your thoughts on that, or what's the evidence kind of that you've seen?
Yeah, so intermittent fasting is something that's gaining more and more interest in the research world, and it's gaining more and more traction from different individuals. And I think the question is what the purpose of your intermittent fasting is. Are you intermittent fasting because you want to lose weight, or are you intermittent fasting because you want to live longer and want to avoid future heart attacks? At the current moment, there isn't strong evidence that says that intermittent fasting reduces risks of heart attacks, stroke, and death. It hasn't been studied in that way. But we do know that some individuals will benefit from doing intermittent fasting because it helps them lose weight. And we know that losing weight and maintaining a normal body mass index has been shown also to be preventative from a heart standpoint. Weight and waist to hip ratio all are important aspects in terms of risk factors. So if it helps you lose weight, then that may be beneficial for you. But typically, the process that we think about for people who are overweight to lose weight is calorie restriction. Whatever diet helps you restrict calories is going to be the one that's going to help you lose weight, right? So if you happen to be on a keto diet, some people do keto as an example, they can lose weight. Some people do a vegan diet, on the other hand, and still lose weight. And then some people are in the middle, are able to lose weight through other means. So what we do know is that for weight loss specifically, and I won't talk about heart health or living longer because we don't have data for that, but if you want to lose weight, so long as you stick to a diet that is restricted in terms of calories, that's going to be how you're going to lose weight. And the typical process is looking at how much calories your body requires to function in a given day, or how much you've burnt based on doing exercise, and then what your intake is. And if you're in a negative or a deficit state, then you're going to lose weight. Typically, the way we think about it is 3,500 calories negative is the equivalent of 1 pound. So if you know that your basal metabolic rate as whatever your weight is happens to be 2,000 calories, then if you eat 1,500 calories, which is negative 500 every day, in a week, you should potentially lose 1 pound, because you would have been 7 times 500 is negative 3,500, you'd lose a pound. That's the typical path. It's not so much the diet itself, it's being compliant with the diet that is calorie restricted that we need to keep in mind. Often we have people that...
And it needs to be sustainable, right, for that reason, because if you just lose it, change your diet back to your normal, you'll just gain it right back, right?
Yeah, exactly. So it's all about consistency. It's all about making sure that you're sticking to it. That's the most important thing.
Okay, perfect. Okay, and another question I have from people are, what can you do at home? What devices can they get at home to help their cardiovascular health? So I think about blood pressure machines, but they're not all equal, right? Now with the new wrist blood pressure machines, and then the Apple Watches and all those things that are monitoring heart rate, what do you think is a useful thing for people to have?
Yeah, so in terms of wearables, I think that's kind of along the lines of the question. I think my internet may be a little bit wonky because things were cutting up a little bit. But I think in terms of at-home things, so as a cardiologist, I really appreciate it when my patients will have blood pressure readings and heart rate readings before they come to my clinic visit, because they may come in and their blood pressure reading may be through the roof, But they tell me, listen, it's not usually like this, I promise you. Well, if you have a 2-week log of what your blood pressure readings and your heart rate readings were, then that makes it a lot more believable, because often we do have patients that have something called white coat hypertension, where they come in and for some reason their heart rate just jumps up because they're very anxious. So having those blood pressure monitors can be very helpful. In terms of the blood pressure itself, so it's one thing to have a monitor, it's one thing to actually do it properly. And so, you want to be taking it in the morning after you've taken your medications. You want to be sitting calmly for a few minutes when you do it. Typically, we use the bicep cuffs. They tend to be more accurate. And ideally, you want to do a couple of readings on the left and right arm. You want to do both and document those. And I think that's it's important to do it properly. You want to be sitting and leaning against the wall with your feet on the ground. And the way you do the blood pressure can be very important as well. So, but I think it is very, very helpful. We do see people come in wearing their Apple Watch or Fitbit or whatever smartwatch they have, and they'll tell us what their average heart rate is. That can also be helpful. But just being mindful that these are not the most accurate things in the world at this time. And I think over time, things will hopefully improve in their accuracy.
Okay, perfect. So I saved this question for last, and it is COVID-19 and the heart. We hear this all over the media. We're hearing about, things that COVID is causing, things the vaccine might be causing, and there's a lot of questions around this. And I know you in particular see patients who've had such complications. So what can you say about all of this that's in the media?
Okay, I think I heard that correctly, and it was relating to the heart and COVID-19, and also, we can briefly talk about the vaccine and what have you. So we know that patients that have a history of heart disease or any sort of risk factors, high blood pressure, among other things, you can potentially be at increased risk of bad outcomes with COVID-19. And so we typically will advise those patients to get vaccinated, as we have been telling everybody anyways, because that would likely be beneficial for them. Again, in my population, which is typically elderly and has risk factors, all of that, that's typically what we advise. We do know that COVID-19 can have an effect on the heart itself. And so we know that sorry, I just clicked the mute button by mistake. But what we do know is that patients can get an inflammation of the heart. They can get inflammation of the area around the heart if they get COVID-19. And that can be dangerous as well. Initially, there were some trials that said people that were dying of COVID-19 were often dying due to cardiac issues because of clots in different parts of the body or within the heart. And so we do know that COVID-19, as is the case with any sort of severe issue that relates to a full body issue, there's a severe reaction that happens with this virus throughout the body. And so we do know that it can have an effect everywhere, including the heart. And so we do recognize that, and we do tell our patients to be vaccinated if at all possible.
All right. So I guess with that, thank you for coming here and giving us such a great breakdown of what it is like to get tests, what it means to have a heart attack, how to recognize it. And I know there are so many more questions that I could ask. And it won't end because you have a huge role and responsibility in the hospital, taking care of everything heart related. So thank you so much for your time. And we really appreciate you being here in the middle of a move, which is amazing as well. So, all right. And for our viewers, I do want to say, if you like our series, make sure you've watched our previous series. We've had talks on healthy living, healthy and active living for kids and adults. And next month, I believe we'll have our lung health month. So stay tuned and keep watching, and follow Muslim Meds on Twitter, Instagram, and everywhere else. Thank you for watching.
Awesome. Thank you so much for having me. And thank you so much for a wonderful session. And for those that tuned in, take care. Bye-bye.
Have a great weekend, everyone. Bye.